Arushi here. Ma'am, I have clinical case presentation. So in which hall do I go?
All 6, no?
So you please start your presentation.
Good evening, ma'am.
Hello. Hello.
Ma'am, shall I start, ma'am?
Yes.
Yeah.
Good evening, respected faculty members and all my dear batchmates of various medical colleges across the India. I am Abhishek Kumar Tiwari of late Sri Lakhiram Agarwal Memorial Government Medical College, Raigarh, Chhattisgarh. I will be speaking about the corneal transparency since dry eye is one of the most common problem in our Chhattisgarh state. And in preparation of this presentation, I was guided by Dr. Sopan Samanta, who is a HOD in Government Medical College, Raigarh. So proceeding with the normal anatomy of the cornea, first I will talk about anterior surface. It is elliptical. The posterior surface is circular and its shape is prolate. Its thickness varies. Like you can see, the central thickness is around 0.52 mm and the peripheral corneal thickness is around 0.67 mm. And the radius of curvature, the anterior curvature is more curved, that is 7.8 mm, and the posterior surface is less curved, that is 6.5 mm. Then the refractive power of the cornea. The refractive index of the cornea is around 1.376 and refractive power is 44 to 48 diopter, which is 70% of the total refractive power of the eye. Now some of the basic information about the layers of the cornea. We have epithelial layer which can regenerate. Then we have Bowman's layer which is resistant to trauma. Then we have a stroma which has collagen bundles with keratocytes. Then we have Descemet's layer. Then we have endothelium which has hexagonal cells, that is 3000 cells per mm square. Then factors responsible for maintaining the corneal transparency. The factors can be grouped under two categories. First is the anatomical factors, then is the physiological factors. The anatomical factors are corneal epithelium and tear film, the peculiar arrangement of the corneal lamella, peculiar refractive index of the corneal lamella, avascularity of the cornea, and the corneal endothelium. The physiological factor can be grouped into relative state of corneal dehydration and the presence of corneal crystallines. Now first, corneal epithelium. The epithelial cells are closely packed and they are uniform and regular in diameter. They are homogeneous in refractive index and there are tight intercellular junction. Now the tear film keeps the epithelial surface moist and it also provides high quality optical surface. Basically the lipid layer of the tear film is responsible for this and it is secreted by the meibomial glands. Now again moving to arrangement of the stromal lamellae. We have two theories. One is the Morris theory and other is the theory of Goldman and Benedek. The Morris theory states that collagen fibers are uniform in diameter and there is, according to theory of Goldman and Benedek, there is equal distance between the collagen fibers, that is half the wavelength of the light, that causes destructive interference for cancellation of the light. Now we have endothelium. In endothelium, we have single layer of cells. This is homogeneous layer. It has closely packed cells and it has detergence function. The normal number of cells in the endothelium are around 2500 to 3000 cells. If the number of cells become more than 500 but less than 2400, means in between 500 to 2400, the corneal endothelium can regenerate by two processes. One is polymegathism, other is polymorphism. Polymegathism means multiple cells enlarge themselves, and polymorphism is multiple cells change their shapes. Now physiological factors. Normal cornea maintains itself in a state of relative dehydration, which is essential for corneal transparency. It is kept constant by factors which draw water in the cornea, factors which prevent flow of water from the cornea, and factors which draw water out of the cornea. Factors which draw water in the cornea there are two factors, that is stromal swelling pressure and the intraocular pressure, that is IOP. You can clearly see the stromal swelling pressure and here is intraocular pressure. The factors which prevent the flow of water from the cornea, these are the mechanical barrier functions of the epithelium as well as the endothelium. Now the factors which draw water out of the cornea, this is basically with the help of active pumping action of the endothelium, which is by sodium potassium ATPase pump. So this is all from my side. Thank you.
Okay. So what is the refractive index of cornea? Abhishek, what is the refractive index of cornea? Question to Abhishek.
Yes, ma'am.
What is the refractive index of cornea?
Ma'am, 1.376.
Which one is greater? Refractive index of lens or refractive index of cornea?
When the refractive index of lens is greater, means refractive index of lens is divided into two. It has central part as well as the peripheral part. Central part has around 1.4.
Is it so?
Yes, ma'am.
Is it so?
Yes, ma'am.
Okay. We're done. Next participant. Our next participant. Our next participant.
Ma'am, this is Adrija Ghosh.
Okay.
Ma'am, can I start? I
Yes,
don't know if
yes.
I'm next or not.
Okay. You start. Please start.
Good afternoon to one and all present here. This is Adrija Ghosh. I am a third year medical student in Medical College, Kolkata. The presentation today is on the profile of patients undergoing penetrating keratoplasty in a tertiary healthcare center of Eastern India, and I was guided by Dr. Chandana Chakravarti ma'am. So, beginning with the problem at hand, blindness, as we know, is a major healthcare problem in India and the world overall. So, out of the 7.3 billion people in the world, 39 million are blind and 246 million have moderate to severe visual impairment. Almost half of these cases could be prevented or are yet to be detected or addressed. These values are already very large and are only projected to increase over the years due to various factors such as increasing age of the population, the lifestyle changes, and the slow epidemics of non-communicable diseases. Now, looking at the problem in India, the major causes of blindness in India are cataract, refractive error, glaucoma, followed by corneal blindness. 6.8 million people are found to be having a corneal pathology, out of which 1 million have bilateral blindness. These pathologies all might require keratoplasty, which can be penetrating or lamellar type. Penetrating keratoplasty was the first surgical technique developed since the start of the 20th century for corneal transplantation. Corneal transplantation is the most common type of tissue transplantation made around the world. All layers of the cornea, the epithelium, Bowman's membrane, stroma, descemet, and endothelium, are replaced with donor tissue with the aim of maintaining corneal integrity and improving the vision of the patient. There is an additional need of 25,000 to 30,000 corneas every year, which will be required to meet the increasing burden of corneal blindness in our country. The objective of the study was to identify the clinical profile and the main conditions for which patients undergo penetrating keratoplasty in a tertiary healthcare center in Eastern India. This was a cross-sectional observational study. It included the records of 93 patients over the period of 1 year from January to December 2021. The data was analyzed, based on the age at which they underwent surgery, the sex, religion, and the indication for the surgery. And all patient information was kept confidential. And all of these records were obtained from the hospital records of our college. Now coming to the results and the discussion that were obtained. Out of the 93 patients undergoing keratoplasty, almost 66% were male, and the male to female ratio was 1.9:1. This was in conformity with the studies conducted elsewhere. A reason for this could be the fact that males are exposed to outdoor occupations, and given our socioeconomic conditions, they are more exposed to trauma in agriculture and industrial sectors. Another reason for this could be the fact that women in a large part of our country face negligence due to various causes, and hence corneal defects in them may not present to the OPD at all. Religious distribution of the patients showed a majority of them were practicing Hinduism. The mean age of the patients was 49 years with a standard deviation of 12 years. This is similar to the data obtained in other studies, which showed 45 and 52 years of mean age. The youngest patient was of 17 years and the oldest of 73 years. As clearly shown in this bar graph, the highest number of cases were present in the age group of 50 to 54 years of age. About 70% of the cases were present in the age group 40 to 64 years. One of the major causes for this could be dryness, cataract surgery, degenerations, glaucomas, glaucoma medications, or trachomata scarring, which predisposed this particular age group to corneal ulceration more than the other age groups. The most common indication for corneal keratoplasty was corneal ulceration, which was infective in nature. This is similar to the data obtained in studies, other studies conducted in India. However, there was a study in southern India which showed bullous keratopathy to be the most common indication. There was a study in Brazil which and other developed countries have shown keratoconus to be the most common indication. Pseudophakic bullous keratopathy was seen in 3.2% of the cases only, compared to other studies which show around 20-30% of incidence. There were no cases of aphakic bullous keratopathy, which comes to show that the incidence of aphakic bullous keratopathy and intracapsular cataract surgery has reduced drastically, reflecting an improvement in our infrastructure, surgical techniques, and the availability of trained surgeons. Fungal keratitis was seen in 29 patients, that is about 31% of the cases, and around 11 had perforated cases, showing the extent and the delay in which they were presenting at the hospital, and hypopional present in 11 of them. The high number of keratitis in our country can be related to the poor socioeconomic conditions, the lack of hygiene, and the lack of education. Also, the delay in good quality healthcare facilities. These in turn emphasize the need for us to improve our awareness systems and to reduce the ocular infections and the preventive measures that can be taken, and making primary eye care accessible to all. All the surgeries, the data of which could be obtained of penetrating keratoplasties. The type of keratoplasty surgery depends on the type of disease that the patient presents with, whether it is involving the epithelium, the endothelium, or the stroma. However, in most cases, penetrating keratoplasty is preferred due to the infrastructure available and the level of training of the surgeons. Also, because most of the cases presenting here involved almost full thickness of the cornea. The advantages of deep anterior lamellar keratoplasty of over-penetrating keratoplasty is that it is an extraocular procedure. However, endothelial disorders cannot be managed by an anterior lamellar keratoplasty, which can be controlled with endothelial keratoplasty surgeries. Other advantages include decreased chances of infection and chances of rejection. The number of patients requiring keratoplasty is way higher than the number of surgeries being done. This huge gap between the demand and supply can only be met if there is a strong campaign for eye donation and its awareness. The hospital cornea retrieval program is one such initiative which might serve the purpose of increasing the cornea available for transplantation and thereby reducing the burden of corneal blindness. In conclusion, it can be seen that hospital records serve as an important tool to identify the profile of the patients undergoing keratoplasty. Indirectly, it also assesses the prevalence of diseases that are present and the health situation of the country as a whole. Corneal ulcer was the most common indication for keratoplasty in India from this study. These are the references for the study. I would like to thank Dr. Chandana Chakraborty ma'am for her guidance and Dr. Ashwin Kumar sir, who has always been a source of motivation for us. Thank you to everyone for giving me this platform.
So, Adrija, what was the commonest cause of corneal blindness in your study?
Corneal ulceration.
What type of corneal ulceration?
Infective corneal ulceration. The data on whether it was bacterial or fungal was not adequately available.
Okay. So, is there any graft rejection?
Yes, sir. There was graft rejection in 2 cases.
2 cases. So, what was the cause of graft rejection in those 2 cases?
That value was not available.
Okay, thank you.
Thank you, ma'am.
Our next presenter, please. Next presentation, please.
Ma'am, myself Sharanya, ma'am, can I start presenting?
Yes. Please start.
Is my screen visible, ma'am?
Okay, please start.
Ma'am, is my screen visible, ma'am?
Yes, yes.
Yes, ma'am. Good afternoon, ma'am. Myself Sharanya from Government Medical College, Omangurar. So I'll be presenting on iBank, and I would like to thank our HOD, Dr. Samarapuri sir, who helped me guide to this presentation. So we are going to see introduction to iBank, functions of iBank. Under functions, we have evaluation of donor tissue, harvesting the eyes, methods of preservation, Then we have eye bank personnel, eye collection centers, legal aspects, and facts about eye donation. So first is introduction. So iBank is a non-profit community. So it is an organization which deals with collection, storage, and distribution of cornea for the purpose of grafting, research, and supply of eye tissue for other ophthalmic purposes. Functions of an iBank. First is promotion of eye donation. So they increase awareness about eye donation to the general public. Then is registration of the pledger for eye donation. Then they collect the donated eyes from the deceased. Then they receive and process the donor eyes. Then they preserve the tissue for short-term, intermediate, long-term storage, or very long-term storage. Then there's distribution of the donor tissue to the corneal surgeon, and then research activities for improvement of preservation methodology, corneal substitute, and utilization of other components of the eye. So before doing all this, first they will evaluate the donor tissue. So that's my biomicroscopic evaluation. So they'll grade the cornea as excellent, very good, good, fair, or poor based on the conditions in the epithelium, stroma, arcus senilis, Descemet's membrane, and endothelium. Yeah, they also do specular microscopy for endothelium, microbial evaluation to see if there's any organism, and they do culture of that organism. Then serological screening for HIV, hepatitis B, syphilis. But contraindications when the cornea should not be transplanted is leukemia, active septicemia, or viremia at the time of death, and rabies. Okay, harvesting the eyes. First is enucleation, that is the whole globe is excised. And second one is in situ excision, where only the corneoscleral rim is taken out. Next is preservation of donor tissue. So if the sclera is removed, it will be preserved in alcohol. If the cornea is removed, you have short-term storage, intermediate, and long-term storage. Short-term storage is storing for 24 to 96 hours. So we use moist chamber method and McCary-Kaufman medium, but this MK medium is most commonly used. Next is intermediate storage, that is up to 2 weeks. So we use Optisol GS, Cortisol, and Usol. And long-term storage is for months to years. So we use glycerin, organ culture, and cryopreservation method. Next is personnel who work in an eye bank. So first is eye bank in charge. So he should be a qualified ophthalmologist to evaluate, process, and distribute the donor tissue. Then we have an eye bank technician. So he keeps the eye collection kits ready. Then he will assist in enucleation of the donor eyes, and he will record the data pertaining to the donor material. Then you have a clerk cum storekeeper. So he will maintain all the records and he will coordinate with other eye banks. Then we have a medical social worker. So he's a public relation officer. So he'll give publicity material to the common public, and he will promote voluntary eye donation. Next is driver cum projectionist. So he'll maintain the vehicle of the eye bank, and he'll screen the films of eye donation promotion in the community. Next is eye collection centers. So they are the peripheral satellites of eye bank for better functioning. So we have one center in an urban area with population of more than 2 lakh, and 4 to 5 collection centers will be attached with one eye bank. Then what are the functions of the eye collection center? Again, they do local publicity for eye donation, then registration of voluntary donors, arrangement for collection of eyes after death. Then personnel who are needed for eye collection at the center. You have an ophthalmic technician. He'll be trained in one eye bank. Then we have local honorary workers or voluntary agencies like Lions Club, Rotary Clubs. Then we have honorary ophthalmic surgeon or medical officer who will be trained on enucleation, and he'll be available on call. Next is the legal aspect. So the entire process is regulated by the Transplantation of Human Organs Act 1994, and this is coordinated by National Organ and Tissue Transplant Organization and Hospital Cornea Retrieval Program. Then we have some facts about eye donation. So all ages can donate your cornea. The only thing is that you should have a clear, healthy cornea. Then we should remove the eyes within 6 hours of death. Then if we donate 1%, like one cadaver's eyes, it can give sight to 2 blind people. Then we can donate to any nearest eye bank. And these donated eyes, they cannot be bought or sold with money. And you cannot remove eyes from a living man despite him giving the consent. After he dies only we can remove. Yes, I would like to end this presentation with a quote that from darkness to light, your eyes can make someone else's world bright. Thank you.
Okay, you told some of the points where you cannot take the cornea, but there are some other points. So can you tell me those points?
Ma'am, sorry, ma'am. Can you please repeat the question?
You have told about means contraindication of donor cornea.
Yes, ma'am.
So can you repeat?
Yes, ma'am. Contraindications if you have viremia, leukemia, or rabies at the time of death, then you cannot give, ma'am.
Any
Or
other
your,
point? Any other point?
um,
Any
so
other
it
point?
should be taken within
If
6
the
hours.
if the death is due to unknown causes, isn't it?
Yes, ma'am. Okay, ma'am.
Okay.
Thank you, ma'am.
Good evening, ma'am. Ma'am, can I share my presentation for the iBank?
Yes. Next presentation.
Yes, ma'am. Ma'am, can you see my screen, ma'am?
No. Not yet.
Hello. Can you see
Hello.
my screen, ma'am?
No, no, not yet. Your name is not coming.
Ma'am, my name is Rupal Shukla. Ma'am, can you see my screen now?
No. I can't find your name or presentation.
Ma'am, my name is Rupal Shukla. I am about to present on the topic eye bank as well.
Okay, please start.
There is some technical issues, ma'am. Can I just present it a bit later?
Okay. Yes, I can see now.
Can you see my screen?
Yeah. Yes, I can see you.
Can you see the screen, ma'am? The presentation?
Presentation is not coming. Is it related to eye bank?
Yes, ma'am, it is related to eye bank.
Okay, please try again.
Yes, ma'am, I'm trying. No, share ही नहीं हो रहा है. अरे मैं बता दूँ share कैसे करें? देखो. वर्क ही नहीं कर रहा है. शायद. मैं भी देखती हूँ. कैसे होगा? पता नहीं हैंग हो रहा है मेरा मोबाइल. अब एक मिनट. कहाँ zoom कर? ये नहीं. आपका चालू हुआ था? हाँ चालू हुआ था कि? हाँ हुआ था ना. नहीं मतलब आप स्टार्ट किए थे बोलना? हाँ. फिर स्क्रीन लॉक हो गया कैसे? क्या करोगे?
Who is the next presenter? Hello. 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 Hello.
Yes, ma'am.
So,
I
who
think
is
we are
the
done
next
with the
presenter?
present. I think we are. Is there anybody else is there? I don't think so. There is anybody else.
Okay, so there were only 3 presenters. Hello. Only 3 presentations. Hello.
रूपल शुक्ला विश्वरंजन साहू सरमना रविचंद्रन हो गया अद्रिजा घोष
So only 3 presentations.
no रूपल शुक्ला
Sure. Sure, you can do whatever way you can find it best.
I think she has some connection. See. Hello.
रूमा
Hmm.
हेलो रूमा
হ্যাঁ তোর কানেকশনে কিছু প্রবলেম হচ্ছে বোধহয়
5 candidates were there. They were present at the beginning only.
No, only 3 presentations.
Rupal Shukla
Rupal Shukla, I think she finds some problem in connecting.
हाँ ठीक है we can wait till Vishwaranjan Shahu done. Vishwaranjan Shahu is done.
No. Abhishek, Adrija and Sharanya.
Huh. But they were there in the beginning only. They said they are there. Vishwaranjan Shahu, Abhishek Kumar Tewari and Adrija is already done, no? Abhishek and Adrija already done. Hello.
Yes, ma'am.
So, Chandana দিয়ে
Hello, Ruma.
হল 2 তে কিন্তু 3টে প্রেজেন্টেশনই ছিল
5 names I have sent you. 5 names.
Anybody left?
Another 10 minutes you wait and see whether the rest to join or not. There are 5 presentation in that hall.
Okay. So already 3 presentations is over. So only 2 left.
left. Ask you the names. You just check whether these two can join within 10 minutes. You send the out of this 10 minutes see and then you.
Okay.
Ma'am, am I supposed to close this now?
का जो एग्जाम है ना, जब नहीं दे पाए तो काम कितने से मांगते हैं आपके पास? जब के दिन 5 से बोला एग्जाम का वो तो हो गया, फिर कर दिया। अब कौन बाकी है? और
যারা প্রেজেন্ট করতে পারেনি তাদের জন্য কি আরো ওয়েট করবে নাকি তোমাকে বলবো আমি তো বললাম 10 মিনিট দেখো দেখে বেরিয়ে মানে পাঠাইনি ওয়েট করতে বললাম ওকে কি করবো পাঠিয়ে
Ma'am, should I close the session now?
Hello.
Are there any more presenters?
Rupal Shukla has started screen sharing.
Okay,
Rupal
okay, ma'am.
Shukla. আরেকজন প্রেজেন্ট করতে
Dr. Rupal, you need to go to your presentation.
Is my screen visible?
Hello. Dr.
Sir, is
Rupal,
my
we can't-
screen visible?
No, you need to go to your screen is visible,
Hello?
but your PowerPoint is not.
Is my presentation visible, sir?
No, doctor, absolutely not.
Sir, is my presentation visible, sir?
I think you stopped. Yeah, just a sec. Doctor, you need to, yeah. Just go to your presentation. Now you can see your home screen.
Is my presentation visible?
Have you opened it? Just open your presentation, doctor.
Yes, sir. Thank you, sir.
Doctor, first open your presentation and then do the screen sharing, or if you can open your presentation now, that would be much better.
So is my presentation visible now? Hello?
It's opening, just a sec. She disconnected, I guess.
আমি ছেড়ে দিচ্ছি হলটা, কারণ এতক্ষণ সময় নিয়ে করলাম, চার্জ চলে যাবে।
Now, are we waiting for Dr. Rupal? Ma'am, we are waiting for Dr. Rupal.
Yes,
Okay.
but nothing is visible here.
She's logged off as of now. She's not joined back. She's not
Okay.
here.
So can we stop this session
Okay.
here?
Okay, ma'am. Okay, ma'am.
Okay.
I'm closing now.